Welcome back, everyone. I hope you enjoyed your time and conversations in the concurrent breakout sessions. What a wonderful day we've had so far. We have heard from so many of our own leaders at Morehouse School of Medicine and the National Center for Primary Care, and from experts, leaders, and partners from across the country. We started the day with an inspirational keynote address from Dr. George Rust, who really set the stage and tone for the day. Primary care is about primarily caring. Then we heard an insightful discussion about the history, successes, and challenges of the health equity journey from Dr. Rust, Dr. Satcher, and Dr. Mack, and then did a little deeper dive into the role, responsibility, and needs to strengthen the primary care system and position it to lead efforts to achieve health equity. We had 8 concurrent breakout sessions that covered primary care, community engagement, telehealth, technology, innovation, and leadership. And we will close out the day with what promises to be an inspiring closing keynote speech that will help transition our discussion into day 2, which will focus more on the leadership and policy opportunities to build on the current momentum to achieve health equity. I have been so excited about our closing keynote speaker, who I've admired her work for so many years. I am beyond thrilled to introduce Dr. Dayna Bowen Matthew, Dean of the George Washington University Law School. A nationally recognized lawyer and legal scholar with 3 decades of industry and academic experience, Dean Matthew is the first woman to lead George Washington Law. An expert in health equity and public health policy with a passion for public service, Dean Matthew joined GW in 2020. She previously served on the faculty of the University of Virginia School of Law, where she co-founded and directed the UVA Equity Center, an interdisciplinary research institute dedicated to building relationships between the university and its surrounding community to redress racial and socioeconomic inequality. Prior to her tenure at UVA, she served as professor of law, vice dean, and associate dean of academic affairs at the University of Colorado Law School, where she co-founded and directed the Colorado Health Equity Project, an incubator for medical legal partnerships that removed legal barriers to good health for underrepresented patients. Dean Matthew is now working with scholars across the George Washington University to establish the Equity Institute Initiative at GW, with the mission of creating a university-wide research institute to support research and pedagogy that advances racial, ethnic, and socioeconomic equity in the United States and globally. Dean Matthew has held a number of important positions in the policy world. She served as the Robert Wood Johnson Health Policy Fellow for U.S. Senator Debbie Stabenow, as Senior Advisor in the Office of Civil Rights at the U.S. Environmental Protection Agency, and as a visiting fellow for the Congressional Black Caucus Foundation. She currently serves as a non-resident senior scholar in the Center for Health Policy at the Brookings Institution and is a member of the American Law Institute. She also serves on several public health boards, including the CDC's Advisory Committee on Immunization Practices, COVID-19 Vaccine Working Group, the American Society of Law, Medicine, and Ethics, and the Scientific Advisory Council of the Foundation for Opioid Response Efforts. A prolific writer, she is the author of the best-selling book, Just Medicine, A Cure for Racial Inequality in American Healthcare, the newly released book, Just Health, Treating Structural Racism to Heal America, and is the co-author of a casebook on public health law, ethics, and policy. With numerous articles and book chapters to her credit, Dean Matthew is a prolific scholar in health, public health, and civil rights law. She received a BA in economics from Harvard Radcliffe College, her JD from the UVA School of Law, and a PhD in health and behavioral sciences from the University of Colorado, Denver. Please join me in welcoming Dr. Matthew.
Megan, I'm very grateful for that wonderful introduction. If I've done everything right, you can now hear me. And I have the privilege of speaking to an audience at one of my most treasured and favorite institutions on the planet. I am honored to be here with you at the Morehouse School of Medicine National Center for Primary Care. I'm honored particularly because my journey to become a member of the Morehouse School of Medicine family started way back in 2014 when I first met Daniel Dawes and his association with the Satcher Institute for Health Leadership while I was a health policy fellow at the Robert Wood Johnson Foundation. I then came to know your amazing and indomitable president, Valerie Montgomery Rice, as a member of a group that works on improving health education. But the highlight of my relationship was in 2018 when I had the privilege of being a part of the commencement ceremony and receiving an honorary degree from Morehouse School of Medicine. So I've truly come home to speak to family. And if you don't mind, since it's the end of your day there and my day here, I'm going to speak as though you are family. My subject comes from the book that I've just released, Treating Structural Racism to Heal America. But I'm going to talk with you as though it is your job, as though it is your responsibility, not only to treat disease, to improve health, but also to treat inequality in America. If you truly want to accelerate our journey towards health equity, that acceleration is going to take some out-of-the-box thinking. And the out-of-the-box thinking is going to require that you begin to use law, not just medicine, not just what you learned clinically, but law as one of the tools that you will use to bring about health equity in America. Health is the byproduct of justice, as was stated by Norman Daniels. And this, if you get nothing else, is the core of my message to you today. In order to achieve health equity, you must concern yourselves and dedicate yourselves to achieving health justice. So I'm going to tell you this story in 5 parts. I'll go quickly through most of the sessions in the very beginning, the sections in the very beginning, so that I can linger with you on how your role in treating structural racism looks. So very slowly, I will build the model, the theoretical model in part 1 that describes what structural inequality is. I'll then go to the special case of structural racism, define that, and then pause, slow down here in part 3 to explain what the role of law is, what the cost of ignoring that law is, and then in part 5, share with you what I believe is your role as primary care physicians and clinicians in treating structural racism. This is level setting. We know what health equity means, but I want you to focus on the fact that you cannot achieve health equity unless we eliminate unfair, unjust, and avoidable disparities. When we talk about unjust and avoidable disparities, we start with understanding that structural inequality is such an avoidable disparity. Let me set the table for you by showing you the generic case of structural inequality. So here you see a graph that outlines the Gini index, G-I-N-I. It's a measure, quite simply put, of the difference between the income and wealth of those in the highest quintile in a society and those having income and wealth in the lowest quintile of a society. So put another way, it's the measure between the distance of that between the haves and the have-nots in society. Here you see countries from the United States on the left to the United Kingdom on the right, arrayed in the x-axis. On the left, you see the highest disparity, that is the greatest distance between the top and the bottom earners in a society belongs to the United States. That is to say, we have the greatest structural inequality. Across our society, we have the largest distance in income and wealth between those at the top and the bottom earning quintiles. Now, when you take that index and you cross-tabulate it with a second index here created by 2 researchers, Pickett and Wilkinson, that second index, which is shown here on the left-hand side, the y-axis, measures health and social outcomes. So again, across the bottom, income inequality as measured by the Gini index from the prior slide. On the left side, you see an index that was created using 10 different measures of health outcome. That is the prevalence of death due to heart disease, lung disease, cerebrovascular disease, the difference in educational attainment, the incidence of death due to diabetes. 10 different variables went into creating this index of social and health outcomes, one number on the left. Here's what structural inequality is in the generic case. You see that the nations here, from starting to lower left, Japan, Sweden, Norway, Finland, Belgium, and so forth, are arrayed in a straight and upwardly sloping line. That tells us that as income inequality increases from low on the left-hand side of the x-axis to high on the right-hand side of the x-axis, so too do health and social outcomes worsen. On the left-hand y-axis from the bottom, better health outcomes, to the top, worse health outcomes. And you see that the more inequality that a society experiences, the worse their health and social outcomes are. So then I misspoke earlier when I said that structural inequality was measured by the Gini index. No, simple inequality is measured by the Gini index. Structural inequality shows us on this graph that income inequality will predictably, reliably, and repeatedly throughout every measure of a health and social outcome produce a upwardly sloping relationship, a positive relationship. As income inequality increases, then outcomes and health and social and health outcomes decrease. So again, you see that in the bottom left-hand corner, Japan is the least inequitable society of all of the countries arrayed here, and it has the best health outcomes. On the other hand, in the top right-hand corner, you see that the United States, the greatest health inequality, the greatest distance between the haves and the have-nots, also produces the worst health outcomes. This is what's meant by structural. I can reliably see on many different indices, on many different measures, in many different domains, that the relationship between income inequality and outcomes is predictable and reliable and positive. That is what it means to have structural inequality. We can replicate structural inequality racially as well. This is how we do it, and this is how I define structural racism. Let me start with a story. It is a story I know very well because it involves my parents. They're pictured here, May and Vincent Bowen. This is my parents pictured when they were 47 and 48 years old, respectively. My father, a little overweight, but certainly healthy, at least by appearance, would be dead 2 years after this photograph was taken. That is to say, my father died at age 49, my mother at age 61, and my contention is that their death was caused in no small part by structural racism, by the kind of inequality that repeatedly, reliably replicates itself in the United States by race, by ethnicity, and by color. Now, I'm talking about structural racism, racial inequality in this talk, but you can replicate these kinds of findings by looking at other disadvantaged and underrepresented groups. You can look at structural inequality that affects the LGBTQIA+ community. You can look at structural inequality that affects socioeconomically disadvantaged or geographically disadvantaged or disabled communities. That I am focusing on race and ethnicity is because I am a constitutional law scholar and I study race and ethnicity, but make no mistake about it, structural inequality affects all of us. So back to my parents' story. Why do I say that structural racism is in no small part responsible for their death? Well, first, let me tell you about the structural inequality of wages that affected my father's work pattern. Instead of being able to earn a living wage in one job, he worked 4 jobs, 2 full-time 8-hour jobs and 2 part-time jobs on the weekends. So every day my father would stride through the South Bronx where I grew up, wearing a suit to go to his 9-to-5 job down at the Bowery Savings Bank. Having earned his degree as a real estate appraiser, he would go down and work 9 to 5 every morning, 5 days a week. And he'd come back 5:30 and sit down at the dinner table, eat, go to sleep for a few hours, and then change into overalls. He would then stride to the same subway that he took in the morning to go to one job to drive in the evening as a motorman for the Transit Authority in a second job, 2 8-hour jobs. And then on the weekends, he would be a superintendent and a handyman for real estate buildings in the Brooklyn and Bronx area where we lived. And these 4 jobs were necessary because he could not earn a living wage in any one of them. That's a structural inequality. Now, why was it so important for my father to earn a living wage? Well, because, again, recall I lived in the South Bronx. In order for me to stand here and have the enormous privilege of having been introduced by Megan with all of the accolades of having gone to this school and achieved this degree and gotten an appointment at the George Washington University School of Law as dean, I could not have gone to school in the South Bronx. Structurally, the schools that I was assigned to by my geographic neighborhood were inferior. They were infested with violence. They had no college preparatory courses, and my parents saw this. And in order to get my brother and I out of the neighborhood that we were in, they worked in order to earn enough income to pay their portion of our tuition in private school. Structurally, the neighborhood schools that I went to either produced inferior educational attainment outcomes so that I could not achieve educational options in my work that were given to those students who lived in the neighborhood where I was bused. That is a structural inequality that replicates itself by race because of our neighborhood. So then again, the structural inequality of inferior schools, the structural inequality of inferior income earning potential, aggregated on top of the fact that where I lived was highly polluted, where I lived had a disproportionate burden of violence. So again, my parents' picture here is in Maine because each and every summer they drove my brother and I to Maine or to other states in New England to spend the entire summer in order to get away from the street violence, the overt policing, the highways. I crossed 3 interstate highways to get to school. So you're getting the picture, the aggregate structure of every institution, whether it was employment, education, nutrition. We had no supermarket by the time I went to middle school in my neighborhood in the South Bronx. Whether it was the value of our homes or the quality of the water that we drank, of the air that we breathed, each institution in my neighborhood had an inferior quality I could access if I didn't get out. And in order for my parents to make sure that I got out, they had to work not 1, not 2, not 3, but 4 jobs. That's structural inequality that affects not just my parents. My parents' story is not unique. The color of their skin consign them to the neighborhood where all that I've described is true for every Black and Puerto Rican and Dominican family that lived in the South Bronx with me at the time. And so when one works 2 8-hour jobs and then adds jobs in the middle to get your family out of the neighborhood that would have consigned or resigned me to an underperforming life, that structural racism is an example of why place matters. I use this often. If you've ever heard me speak, this is another bird picture that I use often. This is Flight 1549. It landed on the Hudson River in January of 2009. It was below freezing. 155 people were saved after this emergency landing. But the point that I want to make here is to bring my parents' story home. If you look closely, there are 2 groups of people waiting for rescue. Outside of this plane, there's a large group standing on the wing of the plane. That large group of people has no life jacket, has no protective resources protecting them from the ocean, from the river, the Hudson River. On the other hand, the people who were sitting in the front of the plane are sitting in life rafts. They're wearing life jackets. They have little samples of food to eat if they are there for any length of time. They have flares to wave for help. In other words, their life chances are markedly better, even under the most adverse of circumstances, being visited upon. All of the people who got out of that plane, all 155 people, are outside of the plane, are looking for rescue, but the large group in the back, because of where they sat on the plane, has a much less likely positive outcome in adversity than the small group in the front. This is another way of saying that place matters. Where my parents lived in the South Bronx is an example of this object lesson that we learned from Flight 1549. Where they lived structurally defined their life chances. We saw this in COVID. These numbers are very familiar to you. The disparities are very familiar to you. And the fact that the hotspots started in neighborhoods like the South Bronx, where we live, densely populated, not very good food options, fewer healthy green spaces, lower quality housing, where I worked, right? My father drove this subway, but 25% of all public transportation riders in New York City are Black and brown. And during the COVID pandemic, that made a difference. I drove to work in the isolation of my car. I stood before my screen in a room that was empty, indeed in a school that was empty. The people who had to go to work, like my father, were exposed to COVID disproportionately because of where they worked and where they learned. My father took that job because he went to schools similar to those that he worked hard to make sure I didn't have to go to, where the teachers were inexperienced, where the course curriculum was inferior, where the achievement gap is no surprise because of the disparities between these schools. Now, I'm not telling you anything that's not true both in rural America as well as in central metropolitan areas. But let me conclude this portion by defining structural racism. Structural racism is a system, not an attitude, not a prejudice, not a bigotry at an individual level. No, it's a system that works throughout society. Remember the Gini index that I showed you earlier. Remember the array that repeats itself. That's what I mean by a system and a structure. So structural racism does two things efficiently. Please remember these two things. Number one, it arranges people hierarchically by the way that they look. More valuable, less valuable, inferior, superior, advantage, disadvantage, along an array by value based on how we look, right? Because there's no biological difference that defines race. So how we look is arrayed in a hierarchy by structural racism. And then the second thing that structural racism does is this. It assigns all of the resources, the power, and the opportunity in society according to that hierarchical arrangement. So you get better housing if you are hierarchically higher in the arrangement that structural racism accomplishes and affects in society. You get better food, you get better jobs, you get better air to breathe, water to drink. You get much better place on the plane based on the hierarchy that structural racism defines in our society. That's structural racism. The theory of my talk and my theoretical conceptual argument to you is based on this diagram. We have spent a lot of time, and I spent a lot of time in my first book and my early research, looking at bias, interpersonal prejudice at the top of this diagram, looking at the social determinants of health and how they impact health outcomes. I am calling your attention in this talk. I am asking you to focus on the foundation of the social determinants disparities, of the disparate health outcomes, and even the biases that we have spent so much time attending to. And I don't mean to take away from those prior conversations and the importance thereof. But your attention now is called to the legalized dehumanization. Let me say that again. The legalized dehumanization, the legalized inequality, and the unequal protection of the law that creates a foundation of structural racism, as I've defined it, to allocate all of the resources of society based on race. It is this legalized foundation that I am asking you as primary care clinicians to become a part of unraveling, of dismantling. You must use law to attack structural racism. So now part 3, what is the role of law? What is this law that you must use? Well, the law has been used to dehumanize, to treat people as though the needs of ordinary human beings are not needed if they belong to certain disfavored groups. This is a quote by Desmond Tutu that makes the point that that dehumanization not only affects the target of dehumanization, but it affects us all. Let me give you an example. We know the colonial examples. That is, enslaved people were sold. This picture is a woman being sold by the pound, using weights on a scale as you would a piece of meat. This is dehumanization. not treating a person as human, as worthy of having emotions. One of my most impactful examples of dehumanization from a legal standpoint comes from a book written by one of the presidents of the United States, Thomas Jefferson. And he wrote a book called Notes on the State of Virginia. In the Notes on the State of Virginia, he exemplified dehumanization when he described the Negro as having more transient griefs, right? The feeling of love, unlike the feeling of love that whites felt. There are examples of dehumanization, of treating one group, whites, as though they have a full spectrum of emotion, and another group, in his term, Negroes, as though they did not. This is what leads to being able to legally commodify a human being's body. Another example from the slave era. This is the story of a slave ship that lost its way in more ways than one. But because it lost its way in terms of the directionality, it had to lighten the load. Those whites in this etching are shown throwing enslaved humans overboard alive in order to lighten their load. These must not be human beings, or we would not treat them in this way. More to the point, when we returned, this ship returned to port, it recovered insurance for the lost property of the human beings that were thrown overboard, legalized dehumanization. But lest you think that that dehumanization occurred only during the colonial period, let me assure you that examples abound. Just one will suffice of our legalizing dehumanization. We said in Flint, Michigan, there is a financial need to save the city of Detroit. We will take this opportunity to withdraw drinking water, a necessity for human beings to live, to withdraw clean drinking water from those who are predominantly Black and poor in Flint, and instead provide putrid drinking water that we can smell, that's brown, that we would not use to create an automobile. This is legalized dehumanization. It happens structurally to Blacks, to Native Americans, to those who are immigrants, to those who are poor. That is what structural racism does. This is structural racism. It convinces us that human beings are different than the others, those who are Black and brown and poor, those who are not like ourselves and therefore do not deserve the same treatment, the same liberty, the same water to drink, air to breathe, conditions to live in. Secondly, structural racism is characterized by legalized inequality. This is very familiar to you. This quote by Frederick Douglass just refreshes our recollection and reminds us that the laws of our country have historically instituted inequality and continue to do so, though not expressly, as in the Jim Crow era. This is an array of segregation laws by state. Not a single state in the Union did not have segregation laws, whether it was for buses, trains, railroads, or even cemeteries. I'm Black, you're white, you can't even in death be buried next to me. But these legalized inequalities manifest today in the third pillar, if you will, of structural racism, that is unequal protection of the law. And here we have an extremely disturbing example. Just one will do, but you see them throughout society. On the left, you see the prevalence of marijuana use by race from 2001 to 2019. The green bars are the prevalence of use among Black populations. The yellow bars are the prevalence of use of marijuana by whites. And you see that the tops of these green and yellow bars are not distant. In other words, we can interpret the graph on the left to say that Blacks and whites use marijuana at very similar rates in society. Now let's compare that to the graph on the right. Again, Blacks shown by the green bars and whites shown by the yellow bars. And here we are looking at the arrest rate for marijuana possession between 2001 and 2018. And you see that although the use, same behavior, is similar by race, unequal protection of the law means that one race, Blacks, is more frequently arrested and burdened for the exact same behavior. This is structural racism. Again, legalized dehumanization, legalized inequality, and unequal protection of the law. Why is law so important? Because it is the mechanism that constructs this thing that we are calling structural racism. It creates the hierarchies, institutionalizes the white supremacy, and distributes the resources, and therefore law is the necessary mechanism to dismantle structural racism. Law is the tool that I'd like to convince you, even as clinicians, if you are seeking to accelerate our journey towards health equity, if you indeed want to see in your lifetime equitable health outcomes, we must not only talk about the fact that the social determinants of health are important, but we must fight for equality in each of the social determinants of health in which structural racism has made access and quality inequitable by race and ethnicity. So the cost of structural racism is great, part 4. It has been great over the course of 100 years. I won't linger here because I really do want to keep my promise and spend most of the time on solutions. But here you see a 100-year history from 1915 to 2015. An example of the cost of structural racism is seen in this graph that charts Black and white infant mortality, Black infant mortality in blue, white infant mortality in red. And as you see, from the period of 1915 to 2015, infant mortality has improved for all races. But the line that tells the story on this graph is the gray line on the top, because that is not the absolute number of infant deaths in the first year of life for any race. That is the gap, the distance between Black and white infant mortality rates from 1915 to 2015. And the story is told by looking at both ends of the y-axis. On the left, the gap is approximately 140 lives per 1,000. And on the right, it is virtually the same. 100 years of history. And although the absolute infant mortality rate has declined, the difference between Black and white infant mortality rates has not. Same story with respect to unchanged Black-white death rates. And you see here through the Jim Crow era, the civil rights era, the post-civil rights era, and what I call the Sandoval era based on current Supreme Court law, the difference in death rates has not changed appreciably over the course of 100 years. This is the cost. And how is that cost visited? By unequal access to the social determinants of health. So where our laws used to fight this kind of discrimination and this kind of redlining discrimination, our laws now must fight the relationship. And this is a diagram that I wish you could study. Thomas Leviste et al. Create a pathway, a series of pathways by which racial segregation in housing, inferior quality housing, produces inferior health outcomes. To understand this relationship is to compel primary care physicians to begin to fight not just for access to health insurance, not just for access to vaccinations in the midst of a pandemic, not just for access to clinical solutions, but for civil rights in housing, so that health outcomes that are impacted by the disproportionate burden that residential segregation visits on neighborhoods, on social capital, on individual exposures, will also be brought to bear in improving health equity and health outcomes. Think of my parents, right? We lived in a residentially segregated neighborhood, the wrong place on the plane, if you will, from a resource allocation perspective. By the way, I had a very happy childhood as far as I'm concerned, but my health was disproportionately affected by the fact that I had to cross highways. I had to leave in order to get a decent education. My father had to work 4 jobs. And that residential segregation was the way that we concentrated the inequalities that required the personal choices that led to my father's death at 49. Let me give you another example. The reason, let me conclude this example first, and then I'll give you another one. The reason I start with housing is because residential segregation is one of the most efficient ways of making sure that substandard quality housing and neighborhoods and resources, the inability to afford decent housing will institutionalize poor health outcomes. That's why residential segregation by race, the racialized nature of inferior housing and unaffordable housing is a civil rights issue that is a public health issue. That is your concern. So another way to see it is to look at this dot map of New York City where I grew up. And here, assume that each dot equals a population of 100, and assume that each dot on the left is color-coded by race. So green dots for whites, blue dots for blacks, orange dots for Hispanics, and so forth. So Manhattan, the Long Island of green dots, except for in lower Manhattan, where Asians are concentrated, in what we call Chinatown, pejoratively, in New York City, are predominantly white in Manhattan, right? In Brooklyn, blue dots, predominantly Black populations. And in the South Bronx, as you can see off to the east of Manhattan, blue and orange dots, Black and Hispanic populations. Now, move to the dot map on the right. This is a dot map that shows the concentration of building code violations, inferior heat, moldy carpet, inferior structural staircases, paint lead, lead in the paint, the pest infestations. These building code violations are violations that we can fix by law. But you can see the distribution of those building code violations in New York City. Very few in Manhattan where whites live, lots concentrated in Brooklyn where Blacks live, lots concentrated in the Bronx where Blacks and Latinos live. This is the inequality that is clearly connected to health outcomes and why housing civil rights is a health issue that primary care physicians should be concentrating on. The outcomes by health are very clear. If I live in a pest-infested apartment, then you're giving me albuterol does no good for my asthma. And that's why Asthma Alley is the nickname for the area in the South Bronx that I grew up in, because of the concentration of inequality, the concentration of building code violations, the concentration of inferior housing. Correct this dehumanization that's legalized, this unequal protection of the law, and you will structurally improve asthma disparities. Correct the neighborhood inequality, the civil rights violations of not enforcing the Fair Housing Act, and you will correct this map. The map on the left is a heat map showing food insecurity. Those who answered, a proportion of the residents in the South Bronx who answered that they sometimes or often did not have enough food to eat. Look at where the concentration of dark colors is. That concentration is in the South Bronx. It is darker in Brooklyn, lightest in Manhattan. That's racialized. This again is structural racism. Again, structural, repeatedly evincing the same racialized patterns of inferior and superior outcomes, inferior and superior access to resources. And no surprise on the right, obesity follows the food insecurity. Highest concentration of obesity in New York City, South Bronx and Brooklyn, right? By race. This is structural racism in action. Unequal access to decent educations. Remember, that's what my father was getting away from when he made the choice to work 4 jobs, right? The unequal access to education. This is what we have laws today to prevent. You can't yell at me and tell me I can't go to a school. We have Brown versus Board of Education, but it is much more important today. Another graph for you to study, Carol Hogue, H-O-G-U-E, has explained the various pathways by which inferior schooling produces health inequity. These pathways are every bit as important as the medications that you are able to achieve, obtain for your patients. Your accurate diagnosis, your clinical care teams, all of those important interventions are as important, in my view, as equalizing access to education by law. so that people who are Black and brown early on are not subject to a funding gap of $23 billion. That's what currently separates the funding resources available to Black and predominantly Black and brown school districts in the United States versus white school districts. School districts where the majority of students are enrolled are students of color receive $23 billion less in educational resources. That means that they have, let me go back before I show you that troubling slide. That means they have fewer teachers with great experience. They have a higher teacher turnover. They have fewer courses for AP, IB, and college preparatory courses. They are disciplined at a disparate rate for the same behavior. You see, funding gaps, resource gaps, produce achievement gaps in educational outcomes. That mean that the pipeline to a job that would be one sufficient to pay a living wage is already racially circumscribed, closed off to a majority of Black and brown participants by grade school. It is this inequality, it is this civil rights battle that I'd like to convince you is part of your responsibility as members of the fight for accelerating health equity in the United States of America. Last example, criminal justice used to look like this, and we have laws that prohibit lynching. We have laws that fight against this type of injustice, but not that are being enforced against this type of criminal injustice. The marijuana example, unenforced, unequal protection of the law. The crime rate in the South Bronx, again, look at the most dangerous parts of New York City. They are the South Bronx, not Manhattan, where whites live. It is the South Bronx and Brooklyn. And a corollary to that on the right, it is also the areas of New York City, my hometown, where the poorest quality schools are located. Again, when you see institution after institution structurally racialized, inferior outcomes, you are witnessing systemic racism and you are witnessing a system that is legally enabled. These are disparities in school suspensions. Preschoolers received 2,822 more suspensions, preschoolers, if they were Black than if they were white. 1.5 times more suspensions if they were Alaskan, Native, or multiracial than if they were white. These are structures that are legalized and must be dismantled in order to have educational outcomes that allow where you live, where you work, and where you play to be as healthy if you're white as if you're Latino, Native American, or Black in America. These are, again, disparities in school discipline. This is such an important area that the law could correct, that it is not required that you are a lawyer to correct these. You could be someone who's a part of your PTO, your parent-teacher organization, and you could look at the disparities and begin to correct these civil rights inequalities. All right, so I'm now going to conclude this section about the cost of structural racism by making the point that it costs entire society, not just Blacks, not just browns, not just poor, but the entire society pays the price of structural racism. Racial bias is associated with higher death rates from this particular article due to myocardial infarction. And this is a really interesting study. I can't begin to tell you all of the studies. My favorite is one where we scrape Google searches, data from Google for racial epithets, searches by people who are looking for racial epithets. And the higher the concentration in a geographic area, say a county or a zip code area, of people searching for the N-word and other racial epithets, the higher the death rate for Blacks and for whites, right? So the message here is that structural racism kills us all. So what's your role? I want you to realize that it was physicians that made it possible for us not to have to see this scene or this scene in order to integrate hospitals. But instead, it was a group of physicians and dentists who brought the seminal case, which I'm sure many of you know about, Simpkins v. Cone, that is responsible not only for desegregating over 7,000 hospitals in the United States, but also was the case that gave rise to the Civil Rights Act of 1964. It was a group of 6 physicians, 3 dentists, and 2 patients who brought that case. And my argument is that those who litigated and marched to desegregate hospitals, that was your responsibility during the 50s and the 60s. I would like to posit, I submit for your consideration that this tradition remains your compelling obligation to fight for civil rights today, to fight against structural racism, to pick up the other tool that is not naturally taught in medical school, but that is evident in the data that I've shown you today, that civil rights must be part of your arsenal to fight for the acceleration of health equity. How can you do it? Well, medical legal partnerships are my favorite solution. That is in your health setting, include social workers and law experts, lawyers, attorneys, as part of your care team, so that, to use the albuterol example, if you're sending a kid with asthma home to a building fraught with building code violations, you don't just send them with albuterol or steroids or a nebulizer, but you send them with a lawyer who will demand that the building codes are adhered to. You send them with an attorney who will fight against unfair rent hikes and eviction. You send them with policymakers on their side because you have assumed the obligation, you have accepted the obligation to see housing civil rights as part of your arsenal to fight against disproportionate burdens of asthma. You could see healthcare, especially primary care, where you know whole families, whole histories, you treat whole patients as the center of the fight for affordable housing, for job training, for activity and recreational spaces, for all the public health solutions that are currently being distributed disproportionately because of discrimination, because of structural racism. It's being done in housing by United Healthcare and many others. I'm just going to give a few examples. United Healthcare, after seeing Medicaid data that showed that homeless Medicaid patients will more effectively recover after their housing is stabilized, invested $400 million in affordable housing. Unity Healthcare invested in building a housing center for a housing facility for low-income patients. And do you have to go to business school or to solve poverty? No, these are done by partnerships. That's why I use this hub and spoke example, this graphic to show healthcare at the center of partnerships that would build houses like that one that was built in the western state of Washington. This partnership has led to 596 fewer self-reported cases of homelessness and has had an impressive impact on health outcomes. But it's not just housing. It's been done in Boston University, but nutrition and food insecurity can be fought by health organizations, health providers partnering with grocery stores to create nutrition that's not just a food bank, but options like the Brockton Neighborhood Health Center that floated a set of social impact bonds using tax laws to co-locate a federally qualified health clinic with a grocery store. Similarly, in San Antonio, Texas, partnerships between Baylor College School of Medicine and a culinary school began to treat diabetes with cooking courses and giving food prescriptions. One of my favorites is violence prevention in Wisconsin, where seeing inequities in our criminal justice system wasn't just something that happened and then was forgotten after a teenager left the ER. No. The victims of violence between the ages of 7 and 18 are identified as patients that are followed with treatment, with social workers, with mentors, with activities that take responsibility for the civil rights of patients who are Black and brown from a violence perspective as a healthcare problem. Several examples. I'll end by saying, you start wherever your proximate problem is. You can fight for living wages or civil rights to equitable housing, to equitable education, to equalize any of the determinants of health, to enforce any of the federal, state, or local laws that are civil rights laws. Because health, again, where I started, is a byproduct of justice. And if you, primary care physicians, see that you are a central part of the solution, this stand of redwood trees looks like it's individual trees by themselves, but again, although I'm not an arborist or a botanist, I know that these trees stand tall not because they are individual, but because underneath the surface, under the ground level, they are all connected in a root system. And that root system that connects us all is what I ask you to remember as you look to tomorrow and consider the policy and the legal solutions that are before you. Think of the ways that you, as primary care clinicians, can accelerate the journey to health equity by engaging in the fight for civil rights. I thank you.
Thank you so much. You did not disappoint in inspiring this audience and leading us into the discussion tomorrow about the role of laws and policies. We do have one question from the audience about distinguishing between economics and some of the other factors that you discussed and potentially racism specifically. So the question is, research has found that minorities continue to have disparate health outcomes even after obtaining economic success. Can you speak to how social justice relates to these outcomes?
Yeah, this is theoretically most, I think, poignantly explained by Arlen Geronimos. Arlen Geronimos is a researcher who has described something called the weathering hypothesis. So it doesn't matter what your income level is, you're still weathering the stress of racism in the United States of America. You're still weathering the stress of inequity, the stress of microaggressions, the stress of being othered and the only. So at any income level, the mental health impacts of discrimination and inequality will have an adverse health effect, specifically on mental health as well as on physical health, as well as we've seen by the disparities in allostatic load. The fight for social justice, again, is one that is not just for those who are low income, but we're looking for social justice across all income levels. We're looking for educational opportunities that I do not have to go outside of my neighborhood to obtain. We're looking for the cessation of residential segregation that affects not only low-income families of color, but it is also true, according to the data, that more middle-income families, African-American families, live in concentrated areas of concentrated poverty than poor whites do. So this is something that spans the spectrum, and civil rights that are under-enforced right now because of structural racism will affect all income levels.
Thank you. And just to hit on that last point that you made, and this was resonating with me throughout your talk, is it that we need new laws, or do we need to enforce existing laws?
Both. It's both. So our existing laws right now, if you read them just in terms of the language in the book, you know, it's prohibited that you deny everyone equal protection of the law. What's emblazoned over the Supreme Court, equal justice under the law. If we actually enforce the laws as written, we'd be in a very different position. We'd be in great shape. But the laws that we have right now are not being enforced, and they're not being enforced in part because they've been neutralized by interpretive court decisions. Those interpretations need to be reversed. We have to fight for new laws. We have to enforce some of the new laws that we have. One of the best laws that we have was passed under the ACA. One of the most important civil rights laws that were passed in the last 25 years was Section 1557 of the Affordable Care Act. It's still good law. It's still on the books. We're doing almost nothing with that law where racial and ethnic discrimination is concerned. That's a place for this group of primary care physicians to begin.
Absolutely. Well, thank you so much. Really, really, really appreciate you spending some time with us today. Thank you for the work that you do. And
Well, thank
Really
you very much
appreciate
for having me. I enjoyed it.
Great. So it has been a long day. I'm feeling energized after that closing keynote, and I think it really did set the stage for tomorrow. Tomorrow, we're going to hear from Morehouse School of Medicine's Dean Adrian Tyndall, who will open the summit, and then we will start the leadership discussion with a spotlight on the faculty development program, followed by a panel of leaders from across the health sciences and health systems sector, talk about leadership within organizations. And then in the afternoon, we will have a community dialogue with the mayor of the city of East Point, Mayor Dina Holiday Ingram. That community dialogue, I think, will tie in a lot of what we just heard in the closing keynote, followed by 4 interactive workshops. And then we will close out the 2-day summit with a closing keynote from Dr. Brian Smedley. All of the information for tomorrow's agenda and to access the links in the morning can be found on the event website, ncpchealthequitysummit.com. And we look forward to seeing you tomorrow, and thank you for being with us today.